Good evening, everybody. I hope everybody can see me okay and hear me okay. You're all very welcome to this evening's event. Thank you all for joining us for the sixth and final instalment in our six-part GP webinar series for 2022. Tonight's hour-long webinar is going to explore the role of group or day programs for those experiencing ongoing mental health difficulties, looking at how these programs can be of benefit. Group programs fall into a number of categories, including diagnosis-specific, recovery-focused, and relapse prevention. So throughout the next hour, Edel Fortune, the Day Programs Manager here at St. Patrick's Mental Health Services, will talk us through the types of day programs that are available here at St. Patrick's and who these programs are suitable for. Edel will also look at how GPs, patients can access these programs, the referral criteria, the referral process, and clinical responsibility. Following the presentation, we'll hopefully have time for a short Q&A with Edel. So you can submit any questions you have throughout the webinar using the Q&A function at the bottom of your screens, and we will try and get through as many of those as we can. Before we get started, just a note to say that ICGP CPD certificates will automatically be sent to any GP attending live tonight within the next 4 weeks, and tonight's event is recognised for 1 CPD point. So we'll get started now, and I'll hand you over to Edel.
Thanks, Sinead.
Thanks, Edel.
Hello, everybody. It's lovely to be here, and I'm delighted to have this opportunity to share with you the benefits of referring to a day program, both for yourselves and obviously for the service users themselves. So there may be parts of this that you already know, but I'm going to try and broaden it out to as wide an audience as possible. So first of all, what is the St. Patrick's Mental Health Services Day Service? Well, the day service is the area of our organisation that has responsibility for all programmes which can be attended by service users post-discharge, or those referred directly from either one of our own Dean clinics, which you may be familiar with one of yourselves, or with another external referrer to attend a day programme. So the services then are delivered through programmatic care, which is group care really. And sometimes, you know, service users in particular find the whole concept of group therapy to be a little bit daunting, but as we go along, you can see how beneficial it can be for them. Traditionally, pre-COVID, I suppose, our programs were delivered on site, both in St. Patrick's University Hospital, which is the James's Street site, and also our site at St. Patrick's Lucan, which some of you may know as St. Edmund's Bree. It was rebranded as St. Patrick's Lucan in the last 12 months. But since the pandemic, we had to really radically change how we deliver all our services. So we very quickly, in the space of about 7 to 10 days, moved everything that was on site into an online format. Now, 2.5 years later, some of our programs are back on site, but many of them are currently still delivered by Microsoft Teams, and that's something that our service users continuously tell us that they really value, given that we are a national service. So for service users, particularly that live outside of the Dublin and Leinster area, it's very beneficial for them to be able to access our programs remotely. Just to put in context the size of our day service, in 2021, 1,780 individuals attended a day program. We have about 25 programs, which you'll get a flavour for as we go along. This equates to about over 18,000 half-day attendances. That was for 2021. Just looking at our figures this morning, and we've actually surpassed that figure. Now we're at about 18,500 half-day attendances so far for 2022. So we'll probably have about another 1,000 before the end of the year. So why refer to a day service then? Well, our day services, as I said, are very much programmatic care. They're very useful for diagnosis education. When the service user is diagnosed with a particular illness, the education component of it is something that's very important and very valued for them. attending maybe regular one-to-one therapies, useful adjunct to those treatments. We very much look on it as part of the care continuum. And the group therapy is a very supportive environment for service users. They learn not only from the facilitators, but also from each other. They learn recovery skills, symptom management, relapse prevention, which are all very important to keep the service user, keep them well. We do find, and very often we're asked, well, why day services? Why are these services not provided to service users when they're actually in hospital? Well, one of the main reasons is that when a service user is post an acute phase, or not in an acute phase, that they're much better able to concentrate, and they're much better able to take on board what it is they're learning through the programs. So the programs themselves then are set up to be either diagnosis specific or skills based. And I'll explain the differences as we go along. We typically have up to 12 participants in a program with 1 or 2 facilitators. When we were on site, we would have, with the smaller numbers, we would have had 1 facilitator. We always have 2 facilitators now with the online programs. Currently, as I said, a lot of our services are delivered through TMI, mostly Microsoft Teams. That's our platform of choice in the organization, and that's what we've been using since the start of the pandemic. Teams, I suppose, was basic enough when we started, but now due to demand, I suppose, worldwide, they have things like breakout rooms now available on Teams, very much like Zoom is, and it gives us the opportunity to mirror what we would do in the real life situation, where we would have breakouts and allow service users to work in small groups as part of their program. Most of our programs are closed groups, which means that when a service user starts a program, we don't have new people joining, say on week 2 or week 3 or whatever. There are exceptions to that. Some of them are run more on a modular basis, but a lot of them, and we find the therapeutic benefit of that is much more robust when there's a process to be followed. And as well as that, for service users themselves, they build up that trust and that familiarity with each other, and it gives them a lot more freedom to, I suppose, express themselves when they're known. When they know other people within the group and they feel safe and supported within that group. The programs run anything from 1 to 4 half days per week. So they could be a morning or an afternoon. We have 1 evening program, which I'll tell you about. Some of them are run actually over a full day, but it's generally between 1 and 4 half days per week, and anything from 3 to 12 weeks in duration. So each program is set up in a different way. The length of the program depends really on the therapeutic milieu of that program. Some of our therapies then go on for longer, things like schema therapy and trauma-based programs, which our psychology department run. As I said, our online groups are co-facilitated. One of the main reasons for that is there are 2 actually main reasons for that. One is that if somebody's connectivity becomes unstable, at least there's another therapist to pick that up. And the other one is if a service user is struggling within a group. When we were in the real live situation, we always had other staff members around that could, talk to the person, take them out of the group, support them. In the online situation, we need that extra facilitator there that can take the person outside of the group and follow them up, maybe with a call or with an individual chat to see, what issues need to be addressed. So the programs fall into these 5 categories, really, and I'll very briefly discuss what they are, and then I'll go into more details. So we have CBT-based programs, which are transdiagnostic or diagnosis specific, and they're delivered by our CBT therapists with support from other healthcare professionals multidisciplinary team. And we have our addiction service, which is diagnosis specific across all dependencies, as well as dual diagnosis. Dual diagnosis, as you will be well aware, is a term that's used quite a lot right throughout the healthcare arena. But for our purposes, when we talk about dual diagnosis, one of those diagnoses is always an addiction. So it's some form of addiction with another diagnosis. For example, could be alcohol with anxiety. It could be, cocaine with, psychosis. There's always an addictive component to it. That's delivered by a multidisciplinary team specific to the addiction service and addiction counsellors. But then we have our recovery focused programs, which are transdiagnostic. They're focused very much on recovery. The commonality there, I suppose, is really that everybody attending has experienced a mental health difficulty. So the actual specific diagnosis is not as relevant in this situation. What we would generally recommend to people is that they do their diagnosis specific program first, and then they focus on their recovery based programs, which works quite well. That's again delivered by a multidisciplinary team and recovery skill facilitators, and they're all advanced at advanced level. Our psychology based programs then are transdiagnostic again, and very much focus on individuals with emotional difficulties or trauma, or very ingrained, I suppose, past histories. And they're delivered by our psychology department. And then the eating disorder service, which is obviously diagnosis specific, delivered by a multidisciplinary team who specialise in eating disorders. So you'll see from this next slide that some of the programs here, or some that I have listed, are in a slightly lighter grey. That wasn't an accident, that was deliberate. And the reason that some of them are written in a slightly lighter grey is that they're the ones that are not available directly to yourselves. So the ones in the lighter grey are the ones that we do need to have one of our own multidisciplinary teams refer to those programs. That's not to say that you can't refer to one of our multidisciplinary teams and then have them refer on, but you can't refer directly. So the ones that you can refer directly to then are the ones in the darker colours. So with our CBT-based programs, we have depression recovery program and the bipolar program. The ones you can refer to, I'll go into more detail. We also have anxiety disorders, building healthy self-esteem, and a mood and anxiety group for adolescents. Then we have our addictions programs, alcohol and chemical dependency, regaining recovery, which is a relapse program, and dual diagnosis program. With the addiction programs, the reason that you can't refer to them, that GPs can't refer directly to them, is because they're part of a stepped care model. And that stepped care model always starts with inpatient detox. And that's a 4-week intensive inpatient program. And then the service users go on to the daycare addictions. So our recovery-based programs, then we have the recovery program itself, which is WRAP, Wellness Recovery Action Planning. We have psychosis recovery, not directly, you can't directly refer yourselves. Pathways to Wellness is one of our in-house programs as well, that we started in response to service users who had been through our services for quite a long time and almost fostered a dependency on the organisation, or at least, had a lot of repeat admissions. Pathways to Wellness was started off with the intention of encouraging those people to reintegrate in their own communities, to get used to socializing again within their communities and accessing services outside of the hospital. It has proven to be incredibly successful. Now, COVID was very difficult for the people attending that program, because a lot of the people attending are elderly, because they have, it just tends to be, it wasn't, really geared towards the elderly initially, but I suppose they're the ones that have had a lot of repeated admissions. Obviously, we couldn't have them on site then during COVID. We did follow them up very closely, mostly with phone support, because, again, because of their age, a lot of them, not all of them, but a lot of them didn't have the technological know-how. Some of them did unfortunately get readmitted then because of isolation and stuff like that. But now they're back on site, they're back attending, and they're very happy with that. Access to Recovery is another one that's, again, one of our in-house programs. And it is, as I said earlier, that our programs are very much closed programs. They're set up that way deliberately. Access to Recovery is not, because the structure of the closed programs, service users that are referred may have to wait for one program to end before they can start the program. So if they're just out of hospital and they have to wait 6 or 8 weeks, it can be a very difficult time for them. Access to Recovery is set up for those people so that they can join at any time post-discharge while they're waiting to start another program. And it gives that transition period, I suppose, from hospital to less intensive treatment. As I said, that's not available to yourselves at the moment, but it is, your service people that attend your services, you may come across that they are attending this program. Acceptance commitment therapy, then I'll tell you about mindfulness-based stress reduction. You can refer to those programs, and the eating disorder service you can also refer to, and I'll tell you that in more detail now shortly. Our psychology programs are not directly, with the exception of one, which is one of our eating disorders. You can't refer directly to those because anybody attending one of our psychology-based programs needs to be under the care of a multidisciplinary team with a psychologist. It's because it's the psychologists do all the assessments and the recommendations and that. So those programs are not accessible to yourselves directly, but as I said, you're welcome to referring through our Dean clinics, or obviously if you have inpatients, they can be referred on. And then some of our day programs do include an aftercare component. I know I'm guilty. I don't know if any of the rest of you, but I'm certainly guilty of doing courses in the past where, you finish a course and you're going to change the world, and then life gets in the way, and then you don't put it into practice immediately, and then little by little you forget what you've learned. And it's a bit the same for the service users that have been doing programs. A lot of our programs are very skills based. And if the service users are not putting those skills into practice, they can forget about them. So the aftercare programs give service users the opportunity to come back either fortnightly or monthly, and sometimes bi-monthly, to meet with the individuals that were on the program with them. And as I said earlier, they learn very much from each other and also from the clinicians. And it gives them the opportunity to put their skills into practice, but also to troubleshoot any difficulties that they may have experienced putting those skills into practice. They all have a cut-off point, so they can last up to a year generally. Sometimes then they might go bi-monthly for further 6 months or a year. The ones that have aftercare are the addictions and dual diagnosis service, acceptance commitment therapy, the recovery program, bipolar, depression, living through distress, radical opus, and compassion focused therapy. Those three are some of our psychology programs. So, but they have aftercare components to them as well. So in order for yourselves, to refer to us, there are certain criteria that must be met. First of all, the individual must have a diagnosis of or being treated for a recognized mental health difficulty. I'm not sure if I'm speaking to the converted here or whatever, but not everybody knows how our service is set up. So just to very briefly describe, St. Patrick's Mental Health Services, independent and not-for-profit. So what that means is that we do not receive any external funding from the HSE or from the government or from public funds. We don't. That's the independent piece. The not-for-profit piece means that any funds that we receive for providing care and treatment is reinvested back into providing care and treatment. And we're on very tight margins with that. So that said, then, if an individual is referred to us, they must either have health insurance cover or approved funding. Now, the HSE can fund individuals, but the HSE doesn't fund the organisations, if that makes sense. Or sometimes service users will pay for themselves. Some of the health insurers do not cover day services, so they may cover inpatients, but they don't cover day services. So the ones that don't cover day services are the ESB insurance scheme, the prison officers scheme, and the Garda medical aid. Those three insurers don't cover our day services. The rest of them do. So DHI, Leah, all those do cover our day services. With the programs that you can refer to directly, we need the referrer to retain clinical responsibility for the individual until the program is complete. So that's just an important piece to realise. So I'll go through the ones again in more detail that you can refer to, but you do need to retain that clinical responsibility until the program is complete. You may be requested to see an individual during the program. It's rare, to be honest. It's only if the clinicians have any concerns about the service user while the program is going on. They may ask you to see the service user. But as I say, and generally it would be for something like maybe a medication review. Somebody's fallen asleep in group, or, you know, if there's something that may be preventing the service user from gaining the most out of the program that they're attending. If a mental health crisis occurs during the program, St. Patrick's Mental Health Service has a crisis policy which would be activated, and the individual will, of course, be seen by the team on call if there's a crisis or a particular worry that needs to be addressed straight away. The referral process then, if you're referring somebody, we take referrals from on HealthLink and HealthMail. That they're our best methods of referral now. You know, I suppose gone are the days when we got a letter, please see this individual. You know, we mightn't even have the name. Thankfully, those days are over. So it's great to get the referrals electronically, because it means they have much more traceability as well, and much more easier to deal with them very quickly. We do request that you provide as much detail as possible, and I know HealthLink particularly doesn't, you know, necessarily prompt you to add a lot of detail, but we do need to know the diagnosis or presenting complaint. We need to know not necessarily the health insurance number, because I don't even expect the service users to have that off the top of their head. But if a service user has health insurance, and we'd expect that they would have if they're being referred, that we know what insurer they're with. And the service user themselves, when you're doing the referral, will be able to tell you that. Any medication that they're on, which is very important that we know that. And what program or service is required. Again, you know, it may not always be glaringly obvious to yourselves what they need, but they might need extra support, and that's fine. You know, we can assess them and stream them into, excuse me, any particular service that is deemed necessary, and very often the starting point would be the diagnosis or presenting complaint, or whatever other history that you can provide. So once we receive the referral, we check the insurance. The insurance is verified, and then the referral is electronically passed on to the relevant program clinicians, and they'll assess, first of all, the referral. and then the service user. Many of the programs, as I said already, are closed, so there will be a waiting list. Most wait times are generally no longer than 8 weeks, because the most of the programs don't go on any longer than that. There are some exceptions to that, or sometimes if there's very high demand, they might have to wait for another cycle again. Again, all the referrals are triaged, service users are assessed, so we very much know where the acuity is as well. As I said, you retain clinical responsibility until the program is complete. If there are any issues arising throughout the program, you as the referrer are contacted by one of the program clinicians. So that would be things like if the service user doesn't engage, or withdraws from the program, if they've no insurance, if there are any other concerns, and also when the program is complete, and if there's any recommendations coming out of that. Just one thing that individuals quite often ask us, or at least that has become apparent, is if somebody starts a program and for whatever reason they drop out, is their insurance charged for the whole program? The answer is no. If somebody attends a program and they only attend for one day, they're only charged for that one day. Now, we don't recommend that, because obviously that's part of the referral and assessment process, I suppose, is so that service users are socialized, if you like, into the program. They know what they're getting into, and it prevents that attrition rate. Because if somebody starts a program and they drop out, means they've taken up place that somebody else could have been using. So it's not the most efficient use of time, and it's not good for service users who may be on a waiting list. But as I said, life happens, life gets in the way, and sometimes people do have to withdraw. But just to reiterate, if they do withdraw, they're only charged for what they have attended. And if somebody does, as I say, withdraw for whatever reason, and they need to start again, they can start again. Of course they can. We have an electronic health record system called eSwift. And so when somebody's attending our programs, all the updates and attendances, etc., are added to that medical record. So starting a program, then, the program clinicians or the administrator will contact the service user to arrange, first of all, an assessment, like I said. The assessments are there for a number of reasons. First, suitability for the program, to make sure that the program is right for the service user. And, it's not even that the program mightn't be right for the service user in general, but it might be that it's not right for the service user at that particular time. There might be something else going on in their lives that may, impede their progress within a program. So they might be advised to wait, for the next cycle or whatever. But also for outcomes. We publish an outcomes measures report every year. Our programs would do outcome measures pre-starting a program, sometimes halfway through, and always at the end, just to see what the service user has gained from attending the program, but also to see if there are any deficits within the program, if there's anything that we need to change. So it gives us an opportunity of reflection at the end of each program. The start date then is also given at this time to the service users, so they know when they're starting. If a program is delivered online, and the service user has any concerns about their ability to log in online, or what the process is, or whatever, we, again, at the start of the pandemic, we set up a service called Service User IT Service, SUITS for short. And the SUITS staff will guide the service user through all aspects of getting set up on Microsoft Teams. And also some of our programs now we have a portal. It's still in development, but so it's not on all the programs at the moment. It's called Your Portal, but it's really beginning to revolutionize how we do things, because the service user can receive all their information and be quite interactive with their own portal, which is great. It's working out really well. As I say, not all programs have it yet, because the concentration is currently on our inpatients, but some of our programs do have it. Service users then, before they start, are provided with group rules, group guidelines, and that's a lot around, I suppose, online etiquette, because they mightn't all be familiar with, you know, we've seen some wild and wonderful things with cameras switched on, and, you know, heard things like dogs barking and things like that. So a lot of it would be around the etiquette of being online, but also privacy, things like normal group rule stuff. And then if the service user is required to have any group program material posted to them, we'll do that. Or if they can also get it by email, or as I said, get it through the portal. So it depends really on how the service user likes to work. I mean, some people like to get the paper in their hands so they can write on it. Other people are happy to get it by email or electronically. Also, their insurance documentation, and that's their health insurance documentation, is sent to them, or they can sign that electronically as well. And that's when, on the first day of their program, they need to do that. So I'm just going to go on now and talk about the programs that you can refer to in a little bit more detail. And obviously, as Sinead said, you know, any questions I'll take at the end. So first of all, we have a recovery or RAP program. That's Wellness Recovery Action Planning. It's a trans-diagnostic program. It focuses very much on things like triggers, early warning signs, when things are getting worse, crisis management, support, and post-crisis. We've found that, you know, support and crisis planning, if you like, is very important for service users in their ongoing wellness. They end up with a wellness toolbox, which service users find very, very helpful, and helps people manage their own mental health, but manage it in a very supported way. It also includes decider skills, also includes lifestyle support, relaxation techniques. So it's a very comprehensive program. It runs 2 days per week for 6 weeks. And then there's an aftercare 1.5 day per month for 12 months. Then we have our depression recovery program, is CBT based. We have inputs from, obviously, CBT, specialist nursing, social work, OT, occupational therapy, and pharmacy. It's aimed at those with mild to moderate depressive symptoms. So again, from a risk point of view, it is a day program. You know, we can't have people with, well, there are two elements to, I suppose, severe depression. One is that the service user, if they're severely depressed, is not going to be able to engage in a therapeutic program. Second of all, the risk, if somebody is highly suicidal or, you know, whatever, if there is that risk there, they really should be an inpatient. So it's the mild to moderate depressive symptoms. Very much, and this, I think, is a program that, from a GP point of view, might be very, very useful to refer to, because we all know that there are lots of service users, lots of individuals attending GPs that are on, and very effectively on, antidepressants, and, you know, leading their lives to the best of their ability, but they could probably function better. Some of them could function better if they had maybe that extra support or the extra education around diagnosis and the techniques on how to stay well. So I think this is one in particular, the depression recovery program, that fits very well with GP referral. As it focuses on the education, the symptom management, the relapse prevention, and improved quality of life. CBT, I suppose, is something that not everybody is immediately drawn to, and they don't always understand how CBT works. So rather than start somebody on an intensive 10-week program, and perhaps they drop out, or they don't, you know, they think, well, this isn't for me. We do run a half-day workshop in advance of the main program, so that the service user can, the CBT model can be explained, the approach is explained, and people are socialized into the program so that they know exactly what to expect when they start the full program. runs one full day per week. For 10 weeks, there's a break of a week in halfway through. And then there's Aftercare, 1/2 day per month for 12 months. Bipolar program, set up in a similar way to the depression program. It all falls under our mood disorders umbrella, CBT based, with some compassion focused therapy and some mindfulness-based stress reduction. The inputs are from CBT, from specialist nursing, social worker, OT, and pharmacy. It focuses on symptom recognition and management, sleep hygiene, early warning signs, triggers, support. Very much, especially with bipolar, we would encourage the service users to have a spotter and somebody to, that may notice when they're becoming unwell very often before they notice it themselves. So it's important that that support is there and that it's somebody that's, close enough to them that, first of all, they'll accept help from, but that the supporter is in a position to be that person that's there for them, that link. We do ask, with bipolar disorder in particular, that the service user is post the acute phase of the illness. It can be very disruptive to a program if somebody is acutely unwell, particularly if it's bipolar. Now, sometimes people do become unwell during the program, but the staff are very skilled at dealing with that. It runs 1 day per week for 10 weeks as well, with an aftercare 1/2 day per month. Our eating disorder day service then is a bespoke service depending on service user needs. It's available up to 5 days per week for up to 8 weeks. A lot of the service users, or a lot of the people that attend our eating disorder service have had an inpatient admission, but we do ask that anybody referred has a BMI of above 16.5 for the daycare. The service, again, pre-pandemic, was based on site all the time. Since we came back on site post-pandemic, we have 2 days online now and 3 days on site. The on-site is very important for those people that need meal support. They're there with us for a full day. We provide their snacks, their lunch, and they're supported through the process of eating and making choices. And they also do things like, there's a lot of input from dietetics, from occupational therapy, and it helps. They take service users out to maybe cafes or to shopping, or they do meal prep with them so that the service users can make those choices for themselves. And it's really part of that care continuum. As I said, they don't need to have been inpatients, but the BMI does need to be above 16.5. We have 2 days online as well for that program, and they would be people that either can't attend because of their proximity to the hospital, or that they're at a kind of a further on stage in their recovery. The service includes specialist nursing, social work, psychology, dietetics, occupational therapy, and there's also art therapy as well. We're currently developing a binge eating disorder day program as well, which is a service that we've definitely seen a need for. As I say, it's in development. We hope early in the first quarter of next year that we'll have that up and running. So as part of our eating disorder service as well, we have compassion focused therapy for eating disorders. And this, I mentioned earlier that one of our psychology programs does accept direct referrals, and this is the one. So it focuses on things like shame and guilt and self-criticism. Again, the service user must have a BMI of above 16.5. It's available across all elements of eating disorders, so anorexia, bulimia, binge eating disorder, and eating disorder not specified, not otherwise specified. And there are 4 levels to it. The psychoeducation is a 1-day session for the service user, and that includes an evening session for family and friends, which is very, very helpful with eating disorders. There's a skills training for the service user, which is 8 half-day sessions. Then there's the therapeutic intervention, 1 morning a week for 17 sessions. There's aftercare, which is 3 morning sessions over 2 to 3 months following the therapeutic intervention. And each level is followed by individual review. So you can see it's a very comprehensive and very supportive environment for individuals with eating disorders to be. Acceptance commitment therapy then is, it focuses very much on becoming unstuck, if you like. You know, individuals that become very entrenched in their illness and find it very difficult to move beyond their illness. So acceptance commitment therapy very much helps with that becoming unstuck, reconnecting with values, and improving their psychological flexibility. It includes mindfulness-based stress reduction as well, and it's delivered by ACT therapists and specialist nurses. It runs 1 half-day per week for 10 weeks. There's monthly aftercare for 1 year, and then there's bi-monthly aftercare for a further year. That gives the service users a very good grounding in the skills. It's very skills-based and the skills that they've learned, and very supportive. And we get great feedback from that service. Mindfulness-based stress reduction, then we have a standalone mindfulness-based stress reduction program. It's delivered by mindfulness clinicians who are also mental health professionals with experience in CBT. So there are elements of CBT. There's a lot of understanding and support around mental health difficulties. So I suppose one of the things that you know, we've been asked quite a bit is, you know, why don't I do my mindfulness in my local, well, pre-COVID obviously, do it in my local VEC or do it, you know, my local community centre. The reason really that we would encourage people to do it with us, they don't have to, but is that our clinicians do have that mental health experience, which is very helpful when somebody does have a mental health diagnosis. It includes obviously relaxation techniques with some acceptance commitment therapy and some symptom management. That's 1 evening, and that's the one program that we have in an evening, 1 evening per week for 8 weeks. So all those programs I just mentioned are all ones that are available to yourselves to refer to directly. We also take direct referrals for individual cognitive behavior therapy. So this is individual work, one-on-one. For referral to an individual CBT therapist, please indicate that the individual CBT on the referral, so we know that's what you want the service user to do. Individual therapies are generally not covered by most health insurers, though some of the VHI plans do cover up to 12 sessions. If a service user's insurance does not cover their individual CBT, there is a cost, and the cost is €150 per session. And that's just to let you know, so that, you know, the service users do need to be aware of that. Once we receive the referrals triaged and allocated to a therapist within the CBT department, it's quite a large department, very, very busy, and a lot of demand on it. But different CBT therapists specialize in different areas. So the department heads would triage the referrals and then stream them accordingly. So CBT then is appropriate right across quite a range of mental health difficulties. Depression obviously is one of the ones that we use it a lot. Anxiety disorders, which includes phobias, specific phobias, agoraphobia, social phobia, non-specific phobias, panic disorder, general anxiety disorder, OCD, health anxiety, body dysmorphic disorder, post-traumatic stress, habit disorders, sexual difficulties, eating disorders, low self-esteem, medically unexplained symptoms like chronic pain, chronic fatigue syndrome, sleep problems, and anger problems. So you can see there's quite a wide range of difficulties there that our CBT department do deal with. So that's it. That's me, and I want to thank you for your time. There's a link there to our website if any of you want to get any further information about any of our services, and I'm happy to take any questions. My email address is there. I know, I'm sorry, Sinead. I'm conscious that some of you are watching the recorded version of this, so you won't be able to ask the questions obviously in live time. So my email address is there, edelfortune@stpatsmail.com. If you have any questions at all that I can help with, just give me a mail. The phone number probably not as easy to get me, but the email is, you will usually get me on that. Okay, thank you.
Thank you very much for that, Edel. That was great. I was just going to ask you if you wouldn't mind sharing that link again, and I'll just share it in the chat box so our attendees can access it that way.
That one?
Yeah, perfect. So I'll just take that down in the chat box very quickly. We do have a couple of questions there as well that I'll go through.
Do you want to put my email address in the chat box as well, Sinead?
Perfect, it will do.
You got it?
Great. So both of those have been shared now in the chat box, and I'll just pull up the questions that we have there. So one of the questions is, we have a GP asking, does a patient have to have had an inpatient stay in a mental health service to avail of a day program?
No. They do need to be being treated for a mental health difficulty. So what we're not going to do within our day services is diagnose somebody. So from a GP perspective, you need to be fairly certain what you're referring the service or the person to or for, if that makes sense.
Perfect. That actually leads on nicely to the next question, which is, how do I know which day program might be suitable for my patient? So would the referral and assessment service be able to advise on that? Or?
Yeah, so it suffices to say, when you're referring either by HealthLink or HealthMail, to say, I have this person, these are the symptoms, or this is what they're currently being treated for. I think they may may be suitable for a day program. And then a referral and assessment service will triage that and forward it on accordingly.
Brilliant. And then we have another question there as well, just in relation to aftercare. So is that included in the standard day programs that have aftercare as part of them, or would that be separate for health insurance purposes?
It's included, but as I was saying earlier, that if a service user attends for 2 half days out of a possible 10, they're only charged for that 2 half days. So if somebody completes the program and they decide, because aftercare is not mandatory, they don't have to do it. So if the service user decides, right, okay, I've finished the program, I don't need to do aftercare, I don't want to do aftercare, or it doesn't suit me to do aftercare, then they're not going to be charged for that aftercare.
Perfect.
So we only charge the health insurers or the service user themselves if they're self-paying. We only charge them for what they attend. They're not charged for if they're not there. They're not charged.
Okay, great. Hopefully that should answer that. And then we just have one final question there. Just pull that up. So it's, if a patient is availing of a day service program, but it transpires then that they might require inpatient care, is there a process around that?
There is, of course. The clinicians that work on the programs are very, very skilled. They're very, they would definitely pick up on any difficulties that a service user may have and would refer them on for inpatient care. Yeah. Obviously they'd contact the referrer at, say, you know, I feel this person may need inpatient care. Is it okay to refer them on?
Perfect. Okay. I think that seems to be it.
Something popped up there about
Oh.
discount for people with medical cards.
Oh, yes. For CBT. So medical card holders for CBT. No. Okay.
No. We're, as I said at the beginning, you may have missed it, we're independent, not-for-profit organisation. We're funded, we're not funded externally. And no, even if a service user has a medical card, they still pay their €150 for their individual CBT.
Okay, that's great. Has anybody got any more questions there? And if not, we might just wrap it up. I might just give it another minute to see if anybody has anything else they wanted to check. Nope, all quiet. Your timekeeping is excellent, Edel. We have Fabian there coming in to say thanks a lot for the talk. I know with a couple of these webinars we tend to run over, so I'm sure it's always welcome among GPs when we manage to finish up a few minutes early. So thanks very much to you, Edel, for presenting this evening, and I hope our GPs attending this evening found it useful as well. We will be sharing a recording of the webinar again, so if there's anything that you want to revisit, you'll have the chance to look back on that. Before we sign off in this evening's webinar as well, you will see a link on your screen where you can share feedback. So if you do have 2 minutes, we'd love to hear your thoughts. We use this feedback to help us inform future events. We'll be doing the GP webinar series again in 2023. So if you have any ideas on topics that you might be interested in, or just any feedback on how we can improve the webinars, we'd love to hear it. And then finally, as I mentioned at the beginning, CPD points are available to any GP attending live this evening. So those certs for the ICGP will be automatically sent to you within the next 4 weeks. And that's it from us. Thank you all very much. I hope you all have a lovely evening and a lovely Christmas ahead. And thanks, Edel.
Thank you all. Thanks, Sinead, and thanks everybody for attending.
Take care.
Bye.